Thanks for reminding some of you. All right. Well, let me just stop sharing my screen. All right, we're right on time. Okay. So, good morning from Singapore. Good afternoon to all of you in Australia. My name is June. Was one of the neonatal fellow in Royal many years ago, and I want to thank Julie and Kurt for having me chair today's very special session. We're hosting Dr. Tetsuya Isayama on a very, very important topic today. So just a quick introduction, not that he needs many. He is the current head of the Division of Neonatology at National Center for Child Health and Development in Tokyo, Japan. Dr. Isayama's research primarily focused on the management and outcomes of extremely preterm infants and has contributed significantly to the international guidelines neonatal resuscitation guidelines, and has also published extensively in neonatology, epidemiology, and clinical practices. In addition, his clinical and research endeavors, Dr. Isayama leads the Asian Neonatal Network Collaboration, and I'm probably seeing some of the network members here in the audience, aiming to improve neonatal care quality across Asia. So today we're very lucky to have Dr. Isayama sharing with us his insights on the management of infants born at 22 weeks gestation, a topic that challenges the boundaries of modern medicine. Notably, advancements in neonatal care had progressively lowered the age of viability with increasing survival at 22 weeks gestation now. His extensive experience and research in this field has been instrumental in shaping protocols and improving survivals for these vulnerable newborns. Without further ado, I know Tetsuya has a pretty thick stack of slides to share with us. I would like to hand over to you, Tetsuya.
Okay, thank you, Dr. Kong. I think I should share, right? Just a minute. Can you see my slide? I think.
You
yes.
want to make it? Yeah, there you go. Perfect.
Oh,
we can see your slides and we can hear you.
Yes. Yeah. So today I will talk about the management of the 20. So the title is 22, but I think 22 to 23 weeks, and especially focusing on the management in Japan. So I'm working in Tokyo, the National Center for Child Health and Development. And so if you have an opportunity to visit Tokyo, please let me know. I can show you the NICU. So first, I will briefly talk about the outcomes of the 22 to 23 weeks in Japan compared with the other countries. And the secondary focus is I will talk mainly today. I will talk about the management of in Japan of this very small baby. So I did I think this presentation I think several times in other countries. So some of you already heard about this. So, but anyway, I will talk first outcome. So I think. I'm working with the other members in this collaboration called the INEO, International Network for Evaluation of Outcomes in Neonate. That's including 11 neonatal networks and 12 countries. And in this collaboration, we have a data about the very robust wet infant. So this is not 22, 23, but for the very robust wet infants, so I highlighted the Japanese data by red color. Japan has a very high rate of the cesarean section for the very robust wet infants. And somehow we have a lower rate of the antenatal steroid. We try to improve this rate. And the outcome born infant is less in Japan, relatively less. And this is an outcome, so the prognosis of the very robust wet infants compared with the other country. In Japan has a very low mortality and a low severe intraventricular hemorrhage or periventricular leukomalacia, so brain injury, and a very low rate of the necrotizing enterocolitis. On the other hand, we have a very high rate of the ROP and the chronic lung disease as a BPD. And as a result, if we think about the composite of these morbidity and the mortality, Japan is not so good. But I think Japan is a very low mortality. IVH net is a very low. And this is another data from the INA group. Probably many of you know this is a survival rate by each gestational age group. And as you can see, if the baby, when the baby become so for lower gestational age infant, um, the between country difference about the survival become bigger. So I think, for example, so 24 weeks, I think Japan is the highest survival, but I think the difference between country become larger. At the time, we did not assess 22, 23 weeks because there are some concern about the population, but I think we are now currently analyzing this 22, 23 weeks outcome. But anyway, the important thing is that outcome difference become bigger for very small gestation age group. So this is a data from the multiple publication comparing the outcome of for the survival of the 22 weeks and the 23 weeks. I summarized these data in this paper, so you can see in the paper. As you can see, Japan, Germany, Sweden tend to have a very high survival for 22, 23 weeks compared with the other country. So I think there are wide variation, especially 22 and the 23 weeks, wide variation between country, the survival. So I'm sure you can see, yeah. For example, in my hospital, this National Center for Child Health, in my hospital, and 6 years, I checked our data, 22 weeks. We don't have many baby, but I think 22 weeks, survival is 89%, and 23 weeks, survival is 94%. Not so many severe interventional hemorrhage. Oh, sorry. Yeah. And this is the data from the National Neonatal Research Network of Japan, and the mortality by gestational age. And this graph showing the gestational age days, each days, how the mortality changed. As you can see, the 22 weeks, 23 weeks. I think even if the same 22 weeks, for example, 22 plus 0 and the 22 plus 6, and that's the mortality kind of a different, double. So I think if the baby is a 22 plus 0, the mortality is close to the 60% in Japan. But if they become a 22 plus 6, the mortality become a 30%. So, and for the 23 weeker, 23 plus 1 is close to the 30%, but 23 plus 6 days, mortality become 15 to 20%. So I think when we talk about the outcome of this very small baby, it's also important to think about the days.
We got
Days, because I think earlier days compared with the later days within the same gestation age strata, the outcome is very different. So I think this is very important for when we do the prenatal counseling for parents. Also, yeah. And this is with neurodevelopmental impairment of the 20 to 24 weeks. 22 to 24 weeks. And I took from these publications, some publication from USA, Sweden, and Japan. And as you can see, I think this is the blue color is mortality, and the red is a neurodevelopmental impairment, and the green is no neurodevelopmental impairment, so intact. And the purple is lost to follow-up. So I think there are some issue regarding the follow-up data in Japan. So that is our limitation. As you can see, we have a good amount of the loss to follow-ups. Actually, so we don't know exact long-term outcome. But anyway, we only have this data. So if we focus on the infant who followed at 3 years, is like this. Just yeah. So can you see my, how to say, pointer? Can you see?
We can.
Okay, okay. I thought, okay, so the bottom part is the baby who followed. I think, and as you can see, the neurodevelopmental impairment is close around 30 to 50% for 22 to 24 weeks. This is a kind of comparative, similar to the USA data and the Sweden data. I think this is important, even if Japan has a high survival, especially compared with the USA. We are not increasing a baby who have a neurodevelopmental impairment. But again, we actually, this is not accurate data because we have a lot of those to follow up. And that is the outcome of this small baby. Oh, sorry. Uh, which, which, oh, oh, sorry. So next, I will talk about management of the, especially the Japanese management of these small baby. Uh, uh, because Japan has a very high survival. So I will talk about what we are doing in Japan. Understanding, this is not the kind of evidence, the description of the each the management of the 22 to 26 weeks. As probably many of you know, now I think many USA person leading this, Dr. Lizabi and the other members leading this tiny baby collaborative, including a multiple center focusing on the outcome and the management of this 22, 23 weeks. And in this collaboration, I'm also a member of this collaboration. And we learn there are wide variation, even if the Uppsala in the Sweden, Iowa in the USA, and Cologne in German. And they are very good, these centers have a very good outcome for 22, 23 weeks. But I think the management have a very wide variation. For example, in Japan, we tend to use a very high humidity and a restricted water intake. And also we are actively treatment, managing circulation using a frequent echocardiography. I will talk this point later today. But for Uppsala, they are using high humidity. But I heard they are not actively treating a PDA, not so much. And they are doing a very early skin to skin. And the care itself is a very gentle, gentle care, nursing care. And Iowa, they are using a very kind of a relatively low humidity and a very much high water intake. And they are actively treating a PDA. But I think the echocardiographies are more targeted, a little bit limited times, but targeted echocardiography. And Kellen, many of you know, I think they are try to avoid the intubation. Even 22, 26, they are using a non-invasive ventilation. But I think as a result, the outcome is all these centers are good. So probably, I think effective management strategy for the very small baby, kind of a combination of the multiple intervention. So there may be no single correct or ideal management approach strategy. So that is my thinking, but I think because of this, I cannot tell what is a good management, what is the right answer. But I think because of this, I will introduce what we are doing generally in Japan. So I think you can, how to say, think about whether that's a management is applicable to in each of your place. So just yeah. So previously I wrote the narrative review article in Translation Pediatrics and this paper. You can see this paper. This is an open journal. And at that time, we don't have exact data about the exact how to say actual data about the clinical practice management for this tiny baby. So after this publication, we performed this national questionnaire survey in 2021. And in this survey, we investigated the very detailed management of the focusing on the 22, 23 weeks babies management. So I will introduce this result. And you can see that in publication archives, the result. And we have a very good response rate, 86%. So a kind of relatively representative of the whole Japanese management. And among 255 NICUs, 145 NICUs take care of the 22, 23 weeks. I think so. That today's result, so the data I'm showing is mainly come from this 145 NICU in Japan. We ask a lot of the question to in this survey. Sorry. So first question this is we asked below which gestation age will infant not resuscitate at all. So and the majority of the, so this is a unit level survey. So this is the answer is from the 145 NSU. And the majority of the NSU answered the 22 plus 0. So I think that means these unit, they don't resuscitate 21 weeks. But I think some unit, they don't have any threshold. So they may resuscitate 21. And the another question is, we asked at which gestation age or above were infants always resuscitated? So this is a little bit different question. We are asking which gestation age infant are always resuscitated in your unit. I think interestingly, majority, more than half, units said no threshold or 22 plus 0. So that means most of the majority of the, so half of the NICU, if the baby, they have a 22 plus 0, they are always resuscitating. And some other unit, 23 plus 0. I think this data showing the Japan is very active to resuscitate of this very small baby. I don't know this is a good thing, bad thing, but I think this is the situation in Japan. In this survey, also we ask the actual individual patient outcome in each unit, and we calculated the survival, mortality, and no resuscitation, so palliative care. I think so. So before we did not have this data, but I think in this survey we have a data about the baby who did not receive resuscitation. So the palliative care cases, and who died in delivery room, and died in the NICU, and survived to the NICU discharge. And as you can see, 22. So this is a Japan 145 NICU, and oh sorry, more than one. Also, this is a patient. So 22 weeks, 164 patients. Among them, survivor is 53, and I think the important data is 15% received the palliative care. So they did not receive the resuscitation. And only 3% died in the delivery room. So if we focus on the data who admitted to the, who received the active treatment like this. So the data is the same. The survivor is 62 for the 22, and for the 23, close to the 80%. So I think, again, this data showing the, in Japan, only 15, so about 85% baby who born in these kind of relatively large unit received the resuscitation. So I think, again, this data showing the Japanese very active, active resuscitation of this tiny baby. Okay, so next I will talk about the management, actual detail of the management. Oh, sorry, management. The first obstetrics management and the resuscitation. And we asked, so the cesarean section, whether each unit to perform the cesarean section for the fetal indication or not. 22 weeks, 23 weeks. And for the 22 weeks, still not many unit doing a cesarean section for fetal indication. Of course, they probably do section for the maternal indication, but for the fetal indication, they don't do the cesarean section. But if the baby becomes 23 weeks, majority, they do the cesarean section for the fetal indication. And we also asked whether, if you do the cesarean section, whether do you prefer the end-cowl cesarean section, cowl, as much as possible. The interesting thing is many units answered yes. So I think they are using, they prefer end-cowl cesarean section. And end-cowl cesarean section is, as you may know, I think that take out the baby from the uterine, intact membrane. So so that take out the baby without the ruptured membrane. And it's maybe important to prevent the skin injury of the baby uh, because especially 22 weeks have a very fragile skin. And if they have an injury during the delivery, it's very difficult to manage after the birth. So next, umbilical cord management. And this is, I think, 2021. So based on the new guideline after 2020, I think I know the internationally, the cord milking is not recommended for the very small baby. But I think interestingly in Japan, many units still using mainly cord milking. This is for the 20 to 23 weeks. And the only minority mainly performing a delayed cord clamping. So, and we also asked whether do you perform the cord milking after cord clamped or before cord clamped? And the majority doing a cord clamping after cord clamping. So that this is we call the cut cord milking. And who perform the cord milking. Because of this, the mainly pediatrician neonatologist, not obstetrician, performing a cord milking. And this is a video provided by the Dr. Hosono from Saitama Medical Center, showing the cut cord milking, what we are doing. So the already cord cut, long cut and clamped, and untwisted, and slowly milked. Yeah. Oh, sorry. So this is cut cord milk. So I think the important thing is that already milk the umbilical cord are cut, and I think when we untwist the cord, umbilical cord, already blood gradually go into baby by the gravity. So and at the end we milk the cord. I think this video is the original video, but I think probably now it's a little bit fast. We try to do a little bit slower than this video in my unit. And next, we also ask the initial resuscitation procedure in Japan. What is your initial neonatal resuscitation for infant at 20 to 23 weeks? And the some unit immediately intubate without mask bagging ventilation. And majority unit answer the mask. First, they do the mask bag ventilation until heart rate improve, then intubate without waiting for saturation. So I think anyway, I think 70% of the NSU, they are doing the intubation before and not waiting for the saturation improvement. And another 24%, one-fourth, mask back ventilation until saturation and heart rate both improved. I think my unit is between this. We try to improve the saturation, but I think often it's difficult for especially 20 to 23 weeks. So we intubate before the saturation improvement. And we ask the device to use for the resuscitation, 20 to 23. And the majority unit, we are using a flow inflating bag. And the TPS resuscitator is not popular in Japan. I think probably it's very different from other country. I believe many other countries using a TPS mainly, but in Japan, we prefer flow inflating bag. But I'm not sure it's which is good, but I think we are more familiar with the use of the flow inflating bag. And the timing of the surfactant administration, majority of the NICU give the surfactant in the delivery room. And I think 1/3 NICU, they wait until after the infant admit to the NICU, they give the surfactant. So majority giving the surfactant very early in the delivery room. The other thing is the endotracheal tube size. And I think this data showing the how to say appropriate recommended size of the endotracheal tube for the each birth weight and the gestation age in Japan, USA, America, North America, and Europe, based on the guideline. That's a 2020 guideline. And as you can see, for the very small baby, uh, European guideline and USA guideline, I'm not sure that they may change after this, but I think at that time they recommended 2.5. But in Japan, we also including a 2.0. I think, and actually, we often use a 2.0 when we have a difficulty to intubate using a 2.5. And based on the experience, 2.0 is easy to intubate. Of course, the management, respiratory management may be difficult after the admission to the NICU, but using a 2.0 tube, we can use SIMV and HFO. It's as usual, we can use HFO. So we don't have any major difficulty using a 2.0 endotracheal tube for very small baby. So next, I will talk about the acute phase management of the, especially focusing on the intraventricular hemorrhage prevention. So I think the Japanese management is, character is, we are very much focusing on the intraventricular hemorrhage prevention in the initial 72 hours. Oh, I cannot. Okay, it's okay. And first is we are using a very high humidity, 90 to 100% humidity, initial 3 days, and gradually wind after 3 to 4 days. And for the larger gestation age infant, we use a little bit less humidity, but it is still high humidity. And as I said in the beginning, I think it's depend on the unit internationally. But if we use a high humidity, it's maintain skin integrity and avoid excessive water loss. And but its negative side is that it may increase the infection. But if the unit use a low humidity, probably you have to need a lot of the water intake initially. So, but in Japan, we are using a high humidity and a very limited. So initially 60 to 70 cc per kilo per day water intake. So I think one of the major characteristic is in Japanese management is echocardiography. Staff and the fellow and the resident, all staff, fellow resident perform the echocardiography in NICU. And we asked how many times do you perform echocardiography? Initial 3 days for 20 to 23 weeks, baby. And more than half answered 3 times or more per day. And I think other half is twice a day. So minority is once a day, but no NICU perform less than once a day. So at least once a day. And most of the unit performing twice or 3 times a day echocardiography. So how we train the echocardiography is we don't have any official training. Most of the unit is doing on-the-job hands-on training taught by the experienced neonatologist. And NICU fellow, probably NICU fellow resident perform echocardiography every day on all admission in NICU. For example, if we have a TTN baby, actually we don't need to do the echocardiography because we are not suspecting some cardiac issue. But I think as a training, many fellow have performed echocardiography as a training. So I think this practice may, how to say, provide a lot of the opportunity to perform echocardiography for the especially young doctors and gradually improve the skill. And sometimes we have a conference and exchange information, and that is the way we improve our echocardiography skill. But some of the neonatologists in Japan, they go to the pediatric cardiology department a year or 2 years or a few years, and come back to the NICU. And generally, they become a kind of a leader of this area, and they teach the young doctor, not only their unit, in the other unit. So that is a Japanese education system of echocardiography. So we don't have any official training. And this is we asked how many percentage of physicians in your NICU can perform echocardiography. This is, I think these are 2015 data, so a little bit old. I think probably now more people perform echo in many countries. But at that time, 2015, I think this data is from 2015 management. Japan have a high, most of the physicians in NICU can perform echocardiography. Also Finland and Australia too. I think I know the Australia now, many people, young doctor, most of them perform echocardiography. So probably more people are performing echocardiography in NICU. And so this question is that whether do they perform that routinely? So routine echocardiography within 24 hours in Japan, most of the unit. Other country, routine echocardiography 24 to 72 hours. A little bit late routine echocardiography. And some country, the gray, the no routine echocardiography. And the treatment of the PDA, in Japan, many units treat PDA, even if without clinical sign, no clinical sign, only based on the echocardiography finding of the PDA. So this data showing that Japan is actively treating the PDA compared with the other country. I think this data is interesting. Do you monitor PDA with echocardiography during or after PDA treatment? And then we asked, oh, sorry, maybe something about question. But I think, so in Japan, majority unit perform echocardiography after each dose of the treatment. That means the indomethacin, ibuprofen. As you know, the indomethacin, ibuprofen is usually 3 doses per course. And in Japan, after each dose, we perform the echocardiography to check the PDA. The other country, majority unit do the echo only after each course. So you give the indomethacin, ibuprofen, 3 doses. After the 1 course, check the echo. So it's I think one of the uniqueness in Japan. And the result of this is that this data is interesting. This data is come from the PLACE study. This is an individual patient cohort data, including more than 600 infants born at 23 to 29 weeks. From 30 NICU. This is an individual, so we have a detailed data about the echocardiography for this baby, initial limited time point. And also we have a detailed data about the treatment. And this data showing the how many doses the infant received for each course of the treatment. At that time, all 30 units using the indomethacin. Now we are using more ibuprofen, but I think at the time, all units using indomethacin. And first course, second course, third course. Interestingly, half of the first course finished only 1 dose. And I think only, 1/4 infants require the full 3 doses for the first course. And the second course, third course are similar. I think this data showing the, oh, sorry. Oh. This data showing, I think we are adjusting the dosage based on the echocardiography after each dose. And I think this may be important to minimize the side effects while maintaining a therapeutic benefit. And oh, sorry. This is another the same survey data. We asked which indices we are using for assessing a baby using echocardiography. And these are kind of very common indices: cardiac function, PDA flow pattern, shunt direction, diameter, And diastolic flow of the left pulmonary artery, it's, I think, personally, I like this most because it's easy to measure and very informative to represent the PDA, hemodynamic significance of the PDA and the LAO ratio. But some, I think, modern half unit using end systolic wall stress. I will talk about a bit later. And I think SVC flow, supraventricular vena cava flow, SVC flow, I think famous internationally and on the paper, but I think in Japan it's a little bit less popular. I'm not sure why, but I think probably it's a little bit difficult to measure, and a lot of the wide inter-operator variation. So that is the reason why we are not using so much. And this is the strategy we are using. When based on the echocardiography, we may find a poor contraction, hypokinetics, and or hypovolemia, or hemodynamically significant PDA, or pulmonary hypertension. And based on these information, we change the treatment. You can see this graph from my open journal paper. I think, and among these strategy, maybe the use of the nitric oxide and checking after load mismatch and using a vasodilator and the use of the hydrocortisone, I think, uniqueness in Japanese management. So here I talk about the afterload mismatch, and afterload mismatch is the when the baby after birth, because the placenta detached, so I think systemic vascular resistance increase, and also the left ventricle received a lot of the blood flow, and especially very small baby, premature infant, have a poor left ventricular function from the beginning anyway. So this leads to the congestive heart failure, and we think it may cause the intraventricular hemorrhage. So we try to, and this condition we call the afterload mismatch. And we try to avoid this condition. I think this Japanese management is detailed in this paper by the Dr. Toyoshima. So if you are interested, you can read this paper. And so in the survey, we asked, do you treat the afterload mismatch? And the majority of the NICU answered yes. So I think many NICU, they are treating afterload mismatch. And what medication we are using to treat this afterload mismatch. And I think most popular one is a vasodilator. That's including nitroglycerin and milrinone. In my unit, often we use the nitroglycerin. And but not often. I think when we have afterload mismatch, we have use nitroglycerin. But I think not so often. We often use diuretics to reduce the preload. That may how to say, reduce the afterload too. And also we increase the sedation. And especially morphine have a vasodilation effect, and that's reduce the afterload. So I think these are treatment strategy to treat the afterload mismatch. The other interesting thing, so this is a data from the Neonatal Research Network Japan about the use of the nitric oxide. And this thick blue is a nitric oxide for the PPHN. So this is an acute phase nitric oxide. And this light blue is a nitric oxide without PPHN. So that means probably most likely these are chronic use of the nitric oxide. And for the 22 to 29 weeks. And this data is the same. If you see the percentage of each infant, gestational age days infants, as you can see, more preterm infant, more premature infant have a more use of the nitric oxide for the acute phase. For example, 22 weeks, 30% of the baby received the acute phase nitric oxide. And for the 23, 25 weeks, baby, 24 weeks, 15 to 20%. So I think this data is interesting because I think probably the nitric oxide have a may be useful or may not be, but that they may be useful for this very small baby management in acute phase. But I think we don't have a strong evidence about this use effectiveness of this, the use of the nitric oxide for small baby. The other important point is positioning and skin care. This is a typical positioning and bending the knee and make cuddle. So make how to say make position like this. And often people are using some skin protective dressing or material under or around the infant for prevent skin injuries. In our unit, we are using hydroxyl polyurethane dressing like this one, surrounding on the bottom of the baby to prevent the skin injury. And this is another picture, another baby. Again, we are using this polyurethane dressing. And also, this is a non-adherent silicone gauze. This is a this baby have some skin injury here, so we put this gauze to prevent further injury of the skin. So I think this kind of skin management may be important to manage because these baby have a very fragile skin. And the other aspect in Japanese management is the sedation. We ask whether how often do you use the sedation or analgesia for 20 to 23 weeks in the initial first weeks, and the majority the majority of the NICU answer that most case or often use the sedation. Some units don't use a sedation, but I think many units are using a sedation for very small baby. And what medication we are using? And fentanyl is a most popular, and the phenobarbital is also, and the midazolam, morphine. I think many units are using a combination of these sedation. Again, we don't have a good evidence for the use of the sedation for very small baby, but I think this is a situation in Japan. So next is the brain ultrasound. How many times we are monitoring the brain ultrasound? As you can see, a majority NICUs answered twice or 3 times a day. So I think usually we are doing a brain ultrasound with the cardiac echo. So I think it's similar to the cardiac echo. And what we are doing using a brain ultrasound is checking the IVH. And if we found a small IVH, we may increase sedation. And also we can discuss about what caused this IVH and how to prevent IVH in the next case. That is, I think, probably important things. And the important thing is that because we are performing a brain ultrasound frequently, we can know when the baby developed the IVH and how that's progress. And that's information, we believe it's important to improve the clinical practice in each unit. And I know, I think many units in other country perform a brain ultrasound after 3 days or 4 days. Of course, you can find the intraventral hemorrhage, but usually at that time, often the intraventral hemorrhage become a massive intraventral hemorrhage. And we don't know when the baby developed the IVH, and we cannot manage the progress of the intraventral hemorrhage. And we also measuring the blood flow in the brain. And especially recently, we are interested in measuring the internal cerebral vein here, ICV. And if this fluctuation of this venous blood flow indicate the risk of the intraventral hemorrhage. There are some data, not strong data, but I think we are now measuring this and try to incorporate this information into clinical practice management. So I think that is a major point today. I quickly go to the other management. Ventilation is very conservative. Usually we start SIMV and change to the HFO after 4 to 5 days. And we don't do the insural LISA for very small baby. Usually less than 28 baby who have an IVH risk, we don't do the insural LISA. And we tend to keep the baby on the mechanical ventilation for a longer period. And the nutrition is initial nutrition day 0-1, minimal enteral feeding, and probiotics is very common. And we are using a glycerin enema regularly. I will talk about briefly this. And the infection is we are monitoring a C-reactive protein. We frequently check the CRP. And I think a majority, almost most NICU wearing the glove for touching the infant. So that is a infection prevention. About the glycerin enema, I think this is probably very unique in Japan. This is for 20 to 23 weeks. How often, so do you routinely use glycerin enema? Majority answered yes. And when do you start glycerin enema? I think half NICU start day 0 or day 1, and some units start day 2 to 3. But anyway, early start of the glycerin enema. And how many times? Majority is 3 times a day. Some unit once a day, twice a day, some unit 4 times a day. So usually we are using 25 to 50% diluted glycerin, warmed, and 2 to 5 cc. Usually we don't use a 5 cc. So usually, sorry, maybe 1 to 2 cc per kilo is for the very small baby. Okay, so I think that's my talk today. In summary, outcome is that we have a very, in Japan, have a very high survival and low rate of IVH and NEC, but a high rate of the ROP and BPD. But I think long-term neurodevelopmental impairment may be similar to other countries, but we have a high loss to follow-up rate. And we do the very active resuscitation and the cesarean section, encounter cesarean section, and the cut cord milking. We using a high humidity and restricted water intake. I mean, minimal handling and positioning and skincare, we focus. And I think most prominent character is a tailor-made circulation management and using a frequent echocardiography and close monitoring of intraventral hemorrhage using a frequent brain ultrasound. And we often use a sedation and nitric oxide are often used for the small baby. And we give the frequent glycerin enema. That is the management in Japan. But again, many of the management doesn't have any strong evidence. This is a kind of example what we are doing in Japan. So I think future study are needed to assess the effectiveness of this management. And by the way, I think our group from Japan, we wrote some textbook summarizing our Japanese management for extremely preterm infant, and that was published. And so if you are interested, you can buy Amazon online. So please go to Amazon for this book. Thank you very much. I'm happy to discuss if you have some questions.
Thank you so much, Dr. Isayama. That was a great talk, and we really appreciate your generous sharing on your experience of taking care of 22 and 23 weeks infants. There's lots of interest in here in the chat pane. I'm gonna go through the questions. First by Dr. Nirmal from Singapore. He wanted to ask if you use nasotracheal intubation in these tiny little babies.
Oh, nasal intubation. As far as I know, I think I think I have never heard using the nasal intubation in Japan. There may be some unit, but I think probably most majority unit prefer the oral intubation. But based on my personal experience, I trained in Toronto,
Right, yeah.
and in Toronto, the Sunnybrook Hospital, they're very good at the nasal intubation. But I feel nasal intubation is a little bit difficult compared with the oral intubation, especially in the resuscitation. So that is the reason why we use the oral intubation. Of course, securing the tube is a little bit difficult compared with the nasal intubation. But I think intubation itself is a little bit easier in the oral. So
yeah, I think we're dealing with space issues as well with the forceps
that's right. That's
little
right.
mouth, right?
Mm.
Yeah, great. So second question, is there an increase of paracetamol use instead of ibuprofen or in the medicine in the centers? So paracetamol versus states, yeah.
I think that's very hot topic, and I think I think probably I know we did the survey, but I think I have not known the result yet. I think we are now summarizing the data, but I don't know that actually the result of the data. So I don't know the general Japanese situation. But as far as I heard from other unit and my unit, especially my unit, usually recently we start using acetaminophen as a second choice
Mm,
after the indomethacin ibuprofen. And
yes.
I think some center in Japan performing a trial assessing the effectiveness of acetaminophen. But I think not so much popular yet in Japan, I
Mm,
think.
yeah.
Mm.
Okay. Um, More questions. What blood pressures do you target, especially considering you using diuretics, vasodilators, and morphine at the same time? Like all these could cause hypotension, right?
Mhm, that's right.
So
I
I
think
want.
yeah, that's a very important, I think, important question. I think, of course, the blood pressure, we don't know the actual ideal blood pressure for very small baby, but I think probably similar to the other country, I think many people in Japan, we are aiming gestation age is similar, above the gestation age, mean blood pressure is above the gestation age. That is a kind of we use. And of course, if we use the vasodilation, that's to reduce, that may cause hypotension. So we have to, but we are using echo and the blood pressure, using both information. We, how to say, we use a combination of the treatment avoiding hypotension, but reducing afterload. And because sometimes some baby have a high, some baby, I think the important thing is that some baby have a relatively good blood pressure. But I
Mhm.
think if we do the echocardiography, the baby's heart is very struggling to pump the blood. That is a typical afterload mismatch. In that case, we try to support the heart and dilate the vasodilation and maintain the blood pressure. So that is important. Even if the blood pressure is good, sometimes the heart is struggling. And we don't know, but I think we believe that is not good for the brain, for the IVH. So I think we try to improve that condition.
So I guess it's very guided by your echograph.
That's
Echograph.
right. That's right. Yeah.
Yeah. All right. So Emma asked, do you commence resuscitation in these babies with 30% FiO2 or higher?
Oh, the initial oxygen?
Initial, yeah.
Oh, I'm not sure. Probably in my unit 30 to 40% oxygen we are using, and often 22, especially 22 weeker. Some often difficult to bug the 22 weeker. So I think often we have to increase to the 100%.
Right.
But I think probably in Japan, compared with the other country, probably Japan, people are not so much pay attention the oxygen, initial oxygen, and I think more probably. But I think yeah, so that is
You
uh,
mentioned that you guys really bag until the heart rate comes up, right? So sounds
that's
like
right, that's right, that's right.
focusing on the heart rate more. Sounds good. For the component of glycerin used in Japan, does it contain sodium chloride? If yes, do you worry about the absorption of sodium load into the circulation?
Oh, I'm not sure. Probably because I'm not sure glycerin. We combine the glycerin fluid with the sterile water, not to saline,
Saline.
and warm up. So probably, in my understanding, that doesn't contain the sodium so much. So I think I think some people think that dilute the glycerin enema with the normal saline. In
Mhm.
that case, that's increase sodium a lot. But I think we are using sterile water with the glycerin to dilute the glycerin enema. So
So that should make
uh,
a
it
difference.
should
Yeah.
be fine.
Yeah. And you don't see a lot of hyponatremia.
No, no, no.
Okay. How much of EBM, express breast milk, would you give to a 22 to 23 weeker in the first 48 hours? You mentioned you start minimal enteral feeding on
Yeah,
day 0 to
I
1.
think yeah, I think it's depend on the probably usually if the 22 week are normal 400 500 gram baby, I think probably 0.5 cc, sometimes four times, and it's depend on doctor. Sometimes we give the 0.3 cc four times or eight times. Usually eight times, four times, and the initial 3 days we maintain that same dosage, and after 4 days, gradually increase.
Okay, I just calculated as well. Less than 10
Mhm.
per kilo per day
Mhm.
safely. Yep. And someone was sharing that data from Iowa used 50% for initial oxygen concentration for resuscitation and
Mhm.
increase survival rate about 19% with the increased RP or BPD. I see.
Mhm.
Yeah, I mean, you did describe the variation in practice, right? Yeah.
Mhm.
What doses of Miruna and nitroglycerin do you start with?
Oh, sorry. I have to check my book.
The drug book, right?
I don't remember the dosage. Sorry. Yeah, sorry.
You say you start on the lower end and titrate. I
That's
mean,
yeah. It's
probably.
usually usually we use a so I think probably half of the minimum dose and
Mhm.
gradually titrate.
I see.
Especially because we are also very scared about the hypotension.
Yes.
So yeah.
Yeah, makes sense.
Mhm.
What parameters used to height fluid stay wise? So, as in, on the first day, you mentioned 60 to 70 milliliter per kilo per day.
Mhm.
Fast do you increase every day, or do you just stay put?
Oh, I think usually, I don't know the other unit, but I think usually 10 cc per kilo per day
Mm.
per increase. The other thing is that is a kind of baseline water intake. And
Right.
sometimes the baby need the transfusion and
Mm.
for the or FFP.
Mm-hmm.
Not often, but I think sometimes the baby needs. In that case, we give the additional to that's baseline to total water intake.
So
Yeah.
that's not counted in the total fluid.
Yeah. So I think that's maybe a 80 cc per kilo per day, or so it's dependent on how much extra treatment we are doing. Yeah.
Right. Do you use prophylaxis for candida infection? What is your decision to
I
start?
think, yeah. I think many units using, and the fluconazole, in our unit, we are using fluconazole prophylaxis.
Mm.
While in the baby have a catheter, we give
Mhm.
fluconazole. I think it depends on the unit, but I think many units using some kind of antifungal treatment, prophylaxis.
Right. And your fungal infection rate is not high as you.
It's very low.
Perfect.
We rarely experience. Recently we have a one case, but I think very rare.
That's
Mhm.
great. And what's your choice for empiric antibiotic usage?
Oh, that is we don't think so. The ampicillin and the amikacin is our unit. I'm not sure other unit. We didn't survey about the type of the antibiotic, so I don't know the other unit. But I think my unit is
Mm.
ampicillin and amikacin.
Right. And as same Dr. Cohen was asking, what is your decision to start antibiotics based on? So do you just because they're 22-weeker, they have so many lines?
Oh, probably many 20 to 23-weeker
Mm,
received antibiotics.
mm,
But I think 20, maybe 23, 24, if the baby is skin good, and especially 24-week, in our unit, we use a 20 to 23-week umbilical venous catheter. In
mm.
that case, it's a little bit become dirty in the umbilicus. So we may give the prophylactic antibiotics, but we may not. So it depends on the doctors and how to think about the condition.
Right.
Especially 24, 20, a little bit bigger baby, if the baby have some sign of the infection and the maternal uh, temperature, choreo, of course, we give the antibiotics prophylaxis. But I think the clean season section, the baby doesn't have any sign, probably we don't start antibiotics.
That's
But at
great.
22 weeks, maybe we may start. So that is based on the doctors and the
Mhm.
timing. Yeah.
Because of the skin condition and all that, right?
Mhm.
Yeah. So Joy was asking, since you have increased BPD, do you know how long they need oxygen after discharge? Do you have data for that? Post
Oh,
oxygen
I'm
requirement.
not I don't have a data about oxygen use. I think, yeah, oxygen use after discharge. My unit, many small, especially 23 weeks, often they need some home oxygen. But I know that some unit are very good at the management of preventing a BPD in Japan. They
Mhm.
don't have any home oxygen baby. So it depends on the, I think, unit.
Let's see. Maybe the
Mhm,
next people for survey.
mhm. That's right.
You continue giving indomethacin doses if the duct has become smaller. So you mentioned you check after every dose.
Mhm.
Would you stop prematurely or would you finish the course, I guess?
Oh, it's really depend on the doctors. But I think in my unit, I'm checking I think many people stop if the PDA become very small, narrow. Of
Hmm.
course, before, of course, if the PDA closed, we stopped. But
Mm-hmm.
if the PDA become narrow enough, and that's not looks like hemodynamically significant, many people stop.
I
And
see.
yeah, so that is our unit, but I don't know the other unit.
I see. And do you see a lot of focal intestinal perforation with the use of your Indesit?
We have sometimes, I think, have a perforation, but I think probably rate of the perforation is a kind of similar, I think, similar to the international one
Mhm.
in terms of the perforation.
Right.
We, especially in Japan, in our unit, we rarely see the neck for the small baby. We have a neck for the big baby complex cases,
Same.
but I think the preterm infant uh, neck is very rare. So, but the perforation is probably similar to the other, I think, unit and the other country, I
Mm,
believe.
that's impressive. Okay, a question
Not,
from Kurt.
mm,
How many ELBW infants will be on cardioactive medications in the first 72 hours? They most of
sorry,
them. How
what I said.
how many less than 1 kilo babies will be on cardioactive medication in the first 72 hours, like inotropes and all that?
Oh, I'm not
Single,
sure.
any?
Less than 1,000, I'm not sure. For example, 20 to 23 weeks, most of them are on the dobutamine or sometimes the dopamine. I think recently we prefer the dobutamine.
Mhm.
We often use the hydrocortisone. So that's most of the 20 to 23 weeks using dobutamine, dopamine, or hydrocortisone. And it really depends on the unit. I think the other day I talked with the other big unit person and in Japan, and they are saying they give the hydrocortisone from the afterbirth, just afterwards, and they don't use dobutamine, the catecholamine, dobutamine most of the case doesn't need. So I think the only hydrocortisone, and after that they don't need
Don't
dopamine.
need
That is
it.
another big
Mhm.
big hospital. So I think it depends on the unit.
I see. Okay, Sally from Sydney. What product do you use on these tiny babies for skin cleansing prior to invasive procedures? Yeah, we often see a lot of skin burns,
Mhm,
even diluted or chlorhexidine without alcohol.
mhm.
She wanted to know what product do you use
For the
to
disinfect,
do
so the
procedures? Yeah, to disinfect.
procedure, I think I cannot say the in English, so I think nothing special. So that I think things yeah, 22 week or 23 week. If we use that's disinfection material on the skin, that's
Mhm.
burn the skin. So when we insert the umbilical venous catheter, we try to clean the only the on the on top of the umbilical cord. And we try to avoid putting this material on the skin. So, but sometimes anyway, we failed and then some baby developed a skin injury. And I think the picture I showed today, the second picture of the baby positioning, that baby have a burn on the skin. So we put some guards, non-attachment guards to protect it. That was very effective and wait until the skin healing. But I think especially 22 weeker, most of the time we have some skin injury, and we kind of putting ointment, normal ointment, nothing special ointment, and that's protective guard. That's kind of a treatment we are doing. Yeah,
Interesting. Yeah. Last two questions, I think. We're coming out of time. Hydrocortisone and Indesit. Yeah, so hydrocortisone and Indesit to be used together is a recipe for disaster, right?
that's
Perforation.
right. That's
You use it together?
No, I think I don't know the detail in other unit, but for example, probably similar in our unit. I think uh, we try to avoid the simultaneous administration of the hydrocortisone and the indomethacin ibuprofen. So I think we always think about the based on the echocardiography, development of the PDA, and the time course of the baby, and the blood pressure. We may start the hydrocortisone first,
Mhm.
and we try to wait until 24 hours after the stabilize the condition, and we give the indomethacin ibuprofen. Of course, sometimes after the hydrocortisone PDA become a very significant in a few hours, and we have to give the indomethacin ibuprofen at that time. So that's happened. But I think we always, balancing the risk and the benefit. We try to avoid, but that sometimes we have to give the a very close time duration. So, but we try to avoid.
Yeah. And do you routinely insert arterial line for blood extractions?
Yes, yes. I think especially small baby, all baby have a umbilical venous. So in our unit, 20 to 23 weeks, umbilical artery. But the 24 or more, baby have a peripheral arterial line. And even 20 to 23 weeks, after I think umbilical arterial lines maybe 5 days later or 6 days, we take out the umbilical arterial line and change to the peripheral arterial line. And because we are closely monitoring the bilirubin and the CRP for a while. So I think we usually, I think probably it's very Japanese management. We collect blood sample probably regularly for a while for small baby from the arterial line.
Just for more frequent monitoring of bloods and all.
Mm-hmm.
Yeah. Okay. There was another question, but it was similar. Just want to address it. How minimal is the feeding initiation in the enteral feeding plan? So I think Dr. Isayama has addressed earlier. He uses about 0.5 mils 3 times, 4 times a day, depending on the clinician discretion. Perfect. Wow, we're coming up to 7 minutes past 1 hour session. Very, very hot topic and lots of interest in the audience. I'm sure anyone else has any burning question, Dr. Isayama wouldn't mind getting an email from you, or you can direct to the organizing committee for Sydney Neonatal Lecture Series. We will forward your question to him. And this talk is recorded, so we will also share the file with everyone. Kurt, would you like to share next week the upcoming talk you mentioned?
So yeah, thanks everybody for attending again. Next week we're gonna have Satyan from America talk about HIE and a recipe of acidosis and PPHN. Fantastic sort of physiological concepts about what's going to happen after HIE. So hope to see you all next week as well.
Well, thank you so much.
Isayama, thank you so much. Thank you so much for presenting.
Fantastic talk. Thank you.
Thank you very much.
Bye.
Bye. Thank you.
Everyone.